I've just pressed the start record button.
Great, thank you. Yep. So we are at 1:30. So welcome everybody. Good to see you all. So let's so apologies for absence. So I think today we've got apologies from James Granger, and I think Rashmi is stepping into that space. We've got apologies from Sally Watson, Trish Dorsey, but I know Karen's here, Jason Stokes, Mark Burgess, and Naomi Woodhouse. So now I lost my other bit. Okay, so that takes us on to declarations of interest, and I don't think there's anything out of the ordinary for that. And then we come to the minutes from our last meeting, which was back in May on 7th of May. So Sarah, again, thank you for a very comprehensive, set of minutes. Are people content that actually we accept those as a true record of the meeting? Yes, I'm not hearing anybody shout or say no, so we'll take that as a signing off the minutes. Thank you. And so then we've got any actions from the action log. I think from memory there were just a couple on there. Is that right? Is that Sadie?
Yes,
Yeah.
that's right, Debbie. We had one that dated back to February, which was about an update on locally commissioned services activity, and James has included that in the finance report, so we can close that. And the other one is the usual one about the minutes.
Great. Yep. Okay. All right. So for information on there, we've got the forward plan. Nothing you wanted to highlight or update for us on that, Sadie?
Just two points, if I may. So you'll see that we've got a couple of red highlights there. One is the pharmaceutical needs assessment, which with advice from our comms team, we've deferred because we're in the pre-election period at the moment. And the other matter was the workforce recruitment and retention programme, the strategic report, which has been deferred due to it still being worked through with the executive team with the new sort of governance controls that we've got at the moment due to our financial position.
Yeah. Okay. All right, that's helpful. Thank you. So that takes us on to, again, I think for noting the risk ratings. I know we've got a more detailed look at the risks later on, have we not? So unless there was anything you wanted to highlight at this point, we'll note this.
The risk register, are you happy for me to do the risk register item now, which is for approval?
Yes. Okay. Yeah. Thank you. Yep.
So you'll see there we've got the usual summary at the beginning, and you may remember from last time that following an audit report we'd been requested to bring all of the risks to committee. We had kind of divided the risks so that the board assurance framework risks came here and everything else went to the delivery group. But now we're bringing them all here once a quarter for your review. I think hopefully you'll see that risk owners have done quite a lot of work on the risks since the last time you saw them. Lots of things highlighted in red there to show that they are changes. Unfortunately not resulting in any improvements in the risk rating, but lots of work going on nonetheless. I wasn't proposing to go into any of the individual risks unless colleagues had any particular questions, but I did want to particularly point out the risk number 19, which we're proposing is a new risk to be added to our risk register. This is a dental risk, which we've identified relatively recently, and it relates to I'm just scrolling through my papers. It relates to secondary care dental services, so particularly oral surgery, maxillofacial services, and orthodontic services. And I think we have some concerns about the level of resilience in those services, and it's fair to say that we don't know all the detail around that yet, so some of that remains unknown. We're certainly concerned about stability of services, and in addition, I think we've become aware of quite a significant waiting time, and with the focus on elective recovery, it's very difficult for these services to get theatre time as well. Plus there are workforce issues, and it's not unique to Norfolk and Waveney, and in fact I think we are in a slightly better position than many in the region. So we wanted to bring this to your attention. As you can see, quite a lot of work's happening within the team. Secondary care commissioning doesn't naturally fit within the primary care team. So we are working that through internally to kind of consider where it sits. We've also been working with our neighbouring ICB, Suffolk and North East Essex, who have offered to lead a team on behalf of the regional ICBs, which as officers we're very supportive of. And in the controls section, we had included that as a control. But I should highlight to you that due to the triple lock process that we're now having to go through, we haven't yet had final approval for that arrangement yet, and the funding that goes with it. So we haven't been able to sign the memorandum of understanding yet. But it is in train. We're hopeful that will come through. But at the moment, rather than being a control, that is a gap. I just wanted to make sure you were aware of that. So that's probably all I was going to say on the risks and that particular risk, but grateful for any comments or questions, and also for members to consider approving that risk to be added to the register. Thank you.
Okay, thanks, Sadie. Hein.
Thanks, Sadie. When I read through it, I can see the resilience of general practice, why you keep the score at 16, but reading the commentary, it does feel like a downward trend. And I guess we need to await whether events will unfold end of July. So that is, I think the committee should be on a watching brief, or is on a watching brief for that. The other point you mentioned the secondary care dental service. So I'm a bit more of a purist, so it needs to have one home, and you could argue you can include many secondary care risks because there's often a close linkage how the system works together. So you mentioned you're talking to colleagues about where does it best fit, but that would be an observation from my side that it doesn't feel like a natural home in primary care commissioning, but that's just my 5 cents on it. Thanks.
Thanks, Hein. Peter.
Thanks. Sadie, you directly spoke to it. I guess I'm unclear why it's on this risk register. As you point out, it's secondary care provision. The commissioning presumably would sit with a secondary care team. If the MOU comes off, actually the suggestion is that the commissioning of it would sit with another ICB on this ICB's behalf, as I understand it. And so that's all I'm testing. Is this the right risk register?
Yeah, I think it's a really good challenge. So secondary care dentistry was delegated to us along with primary and community care dentistry. So it kind of came as a package, if you like. And I think internally we are considering where that best sits at the moment in light of the restructure. So we've been holding, sorry about my dog crying in the background, we've been holding this workload pending the restructure completing. I think even if the work is undertaken by Suffolk and North East Essex, we are still responsible for that. We're not further delegating the responsibility, just the work, if you like, is going to be managed. So just in the same way as we do for pharmacy and optometry with Herts and West Essex ICB, we remain responsible, although they do the work on our behalf. But yeah, we will through reports to the committee, we can keep you updated on those discussions about where it best sits. And it might be that in due course we can move it to another committee.
Okay, thanks, Sadie. Karen.
Thanks. Oh, thanks, Sadie's stroking the dog. Hi, Sadie. Thanks very much for sharing this. My question is around dental services resilience. We're sitting at a 20. When do you look at some of the mitigations? We're certainly not going to resolve this problem in a day, but you've put an awful lot of work into supporting, increasing UDAs, looking at increasing emergency, and the scope and the work you've done in terms of the short-term plan, the long-term plan. Should this really still be a 20? It doesn't devalue the concerns we have, but should we be considering whether this moves, because it shows a shift in the work that you've done, to a 16?
Yeah, I think again another good challenge, and I think for us we probably need to see the results of some of that work coming through. I mean, as I've mentioned, we're in the triple lock process at the moment for our long-term plan investments, so we're waiting for final approval of those, hopefully, so that we can enact those work programs. And I think we'll see later on the agenda, we've got an item around delivery and delivery report, and the sort of areas that we're going to be monitoring this year. And I think we really need to start seeing new patients being treated, for example. And then it would be good to be able to reduce the score. So and yeah, we'll have to see, but I'm hoping it won't be too long. But at the moment we didn't feel comfortable to reduce because we're so early on in that programme of work.
Okay, that's helpful. Thank you. Nick.
Yes, good afternoon, everybody. Two comments really and a question. The first comment is regarding the link between primary and secondary care dental services. I don't think there's many other primary and secondary care groups that actually have such a tight relationship. The impact of what's going on in primary care has a massive knock-on effect on secondary care and vice versa. So it is much more difficult, I think, to unpick those two and put them in different boxes. But I do appreciate that when you look at it, that would seem to be the most natural way of doing it. But actually the combination of those two makes it a much more difficult job than it would appear on the surface. That's the first comment. The second comment is regarding Karen's point about whether we should reduce that that risk rating. Frankly, I've just come back from a national conference listening to many dentists talking, and the situation is becoming more dire than better. And what we're doing is putting our fingers in the dike to hold back the water, but the water is coming out of that dike nationally quicker than we can actually find fingers to plug those holes. So I think it's probably right can I say, to keep it at that level, because depending upon how the next month goes and what happens after that next month, and I'm choosing my words carefully, then we may well find that depending upon what colour we're working under will depend very much on how things change or move on. So I think it's wise to keep that risk register, that risk rating at that level. And an easy one, Sadie, this one should be an easy question. I noticed that you're undertaking a recruitment for a clinical dental advisor. And I know we have dental advisors within Norfolk at the moment. I wonder if you could just give us a better idea of what that person will be doing and whether this is an additional appointment over and above the people that we've got at the moment.
I think it's because the previous arrangements we had up until the end of March with the regional advisors that we had has come to an end.
Okay.
And as such, we are recruiting for a dental clinical advisor that would do, for example, what Tom Norfolk would have once done for us, to help us with some of the work that we're doing, to help us with reviewing complaints, etc.
No, I understand that. That's absolutely fine. It's just basically reappointing or looking for a replacement appointment because their period of office is finished.
That's right.
I know Rich Lawson is working as a dental advisor in Norfolk at the moment, so I was just interested to know if that was an additional appointment. But you've answered my question. Thanks very much.
Thank you.
All right, thank you. So helpful discussions and interesting discussions there about the risk then. So a new risk in there. Some comments on some of the others which you'd already sort of anticipated and thought about, Sadie, as always. But I think that's helpful to hear that. Okay, so I think we're happy to see that new risk on there for now. Someone's got to hold it, so until either it stays or it's got a safe handover, it's absolutely right that we keep hold of it here. So thank you for that.
Thank you.
Okay, all right. So that takes us to community health and wellbeing workers. Olga, I think this is yourself, so welcome. Nice to see you.
Hi, everyone. I don't know if you want me to say a little bit, obviously you have the paper, but as you're aware, the 24-25 GP contract gives PCNs a bigger flexibility on how to use their hours funding. So for the first time, they can use it for roles that are not prescribed exactly as in the contract, but they need ICB approval. In the last 1.5 years, we have been running a pilot with the Breckland PCN, more specifically in the Wharton practice, with 2 new roles, the community health and wellbeing workers. This is something that originated in the favelas of Brazil, but it was brought in London, in Westminster, and it was mentioned also in the full stocktake report. And these roles work very closely with deprived communities. Currently, there are like Band 2s employed by the district council, but fully integrated with the GP surgery. They have full access in all the systems. And what they do on a monthly basis, they knock the doors of these very specific households. They are selected based on soft intelligence and the data about where we have the highest deprivation. The impressive thing, though, is the results that we have seen. And they have increased the uptake of all the preventative type of appointments like vaccination, NHS health checks, screening. And we don't have anymore this, unscheduled calls on the day, because now they know how to navigate the system. We have seen that some of them didn't know how to use Footfall. And so the burden to the practice has reduced. And because it has been so successful in year 2, we have continued the funding. In year 2, the practice is also testing some different use cases, like increasing the vaccination rate and working with frequent attenders in the practice to see how they can support them more holistically. The support that they offer is comprehensive and holistic to the whole of the family. So they also support them with housing, food vouchers and other things. And now they have even started getting blood pressure. So with that in mind, we feel that these roles are very, in some respects, similar in what the social prescribers are doing or care coordinators roles that before we were always able to fund through the ARS funding. And we would like to get approval for practices to be able to use ARS funding for this type of role too, which we believe are very important practices that they're in the core 20 areas.
Brilliant, thank you, Olga. Comments or questions around this? Ian.
Thanks, Debbie. Thanks, Olga. Yeah, an impressive paper and an impressive trial, if you like, through Wotton, building on the Westminster example. Just one observation, really, which is it's really good that we are thinking along the joined up care lines. You talked about the social care, the housing, etc., etc. But fundamentally, picking up from the paper, the observation of these new roles seems to fall to a GP. So again, we are using GP time instead of patient facing for supervision purposes. Is there any kind of control or mitigation of actually reducing available frontline GP time by taking up this supervision?
Yeah, so it's a shame that we don't have Toby here from Wotton. He would say actually that it has saved time to the practice because these people, their lives sometimes are very chaotic. So they actually take a lot of GP appointments wrongly sometimes because they don't know how to navigate the system. So with the support of the community health and wellbeing workers, these people are being actually funneled to the right type of professionals, not the GPs. So that could be mental health services, there could be, preventative appointments, nurses. So actually the GP time that the partner is providing currently is just half an hour a week. We have monitored that. So we actually feel that the benefits to the practice is better. They also have seen an increase in their QOF. So there's a direct benefit also financially to the practice through all this activity.
Okay, thank you.
Right, thanks, Olga. Andrew.
Yeah, just a supportive comment as well, really. I recently heard about a similar scheme at Lowestoft with Lowestoft PCN, and their results and their data are very impressive. And the way I had heard the conversation, the key to it is having, forgive me putting it like this, but ordinary people in those roles, and therefore communicating in a non-professional, non-clinical way with the population. And I know that's worked very well for them.
Thank you, Andrew, because that is actually, I think, the secret of the success. And these are people from the community. They're multilingual, speaking the language of the local community, which sometimes, for example, one of the use cases that is happening now is the Afghan population that they had in Wotton. They felt it was taking so much time, it was so difficult to communicate. So one of the use cases, they gave that. They thought they had 8 people, but actually they had 80 in that community. And with the support of the community health and wellbeing workers, they identified different health issues that they had as a community, and that has saved a lot of time to the practice.
Karen.
Thank you, Olga. I absolutely support this, but I have 2 questions, and actually you've partially answered one now, which is it's always really good to have the qualitative feedback, isn't it? Just exactly what you've described, because it demonstrates the benefits, which gives reassurance to Ian around how it is reducing GP time and it's serving that very much needed population with the additional support to meet their needs. One of my other questions is, do we have the funding? If we make the recommendation, do we have the funding for this to go through? Because I'm conscious we're in triple lock.
So just to answer to both questions, so we obviously have the report from Westminster about the impact. We have our data that shows similar impact, and we currently have £15,000 to do also our own evaluation, because we have seen such actually impressive results that will help us to further promote it. As for the money, because it's from ARS funding, that depends on the individual PCN. So this paper is for the whole of Norfolk and Waveney, and to actually give the opportunity to PCNs to consider if they want and if they have, the allocation. Some of our PCNs obviously have committed 100% already, so we're coming a little bit late, but that doesn't mean that it cannot be used next year. But other PCNs have never used the full allocation of their ARS funding. So if they are in a really deprived area, we would really promote these roles with them.
Mm-hmm. Yeah, thanks, Olga. Shepherd.
I just wanted to say, Olga, thank you. I really feel encouraged with this piece of work, because it talks to really one of our top priorities around addressing health inequalities. And really it connects to people and the communities. And I'm really looking forward to tap into the experience that you've built so that we can also improve in other areas where we are quite challenged in terms of actually connecting to the real people in the community that way. So thank you so much.
Thanks, Shepherd. I think, I'd echo this. I think I've been in sort of 2 presentations where, some of those wonderful people from the Watton area have come and talked about what they did. And, yes, they are ordinary, but they're also extraordinary as well, is my sort of, interpretation of it. I think this is really interesting because with things like this, I know, the Health and Wellbeing Board, the Integrated Care Partnership, has grappled with how do we get these things? So, we do a one-off piece over here and everybody goes, oh, that's wonderful, but no one's got any money to sort of scale it up. Well, I think this is really highly intelligent to bring it into this. I mean, I guess my challenge back would be, how do we sell this now to primary care networks? They've got so much to think about, so many options in a way. How do we do this? And I don't know, Olga, whether there's any thinking in your team about this.
That is a very good challenge, Debbie, because I think so far we couldn't go out and shout so much about it to the PCNs, because the question back is, okay, but where is the funding? And I think that goes back to your comment, that gives it empowers the PCNs to make their own decision if they think that's important and can help them. Now, from our perspective, what we try to do is have our own evaluation, because I think that will speak very loudly to the PCNs if they can see the positive impact to their practice. And we can see, obviously, with the information we have so far, that it offers care in a completely different way. For example, they knocked the door, there was a lady with mental health issues, but then when you start talking with her, they realized her son was autistic and isolated, so they arranged for the son to be connected with local VCSE groups, but also the husband hadn't worked for 5 years, so they supported him, and the gentleman found a job somewhere. So actually, this lady would have gone to the practice again and again just for her medication, and that wouldn't be enough because he had all these issues around her. So we actually offer such a holistic support that would definitely save time to the practice. But I think for us is then to be able to put ourselves in front of the PCNs. And if we have this approval, then that will be easier, because we can say, and this is now an option that you have if you like this project, if it is a priority for your area, you have a mechanism that you can control and use it for your benefit.
Right. Okay, thank you. So I think, we're very happy to support this. And great to have something which feels, in the prevention space, actually. So that's really good. So thank you for that.
Thank you very much.
Olga, you're most welcome to stay, but you may have other things to do, but you're very welcome to stay.
Thank you. I will go now. Thank you.
Okay. Okay. That takes us on then to CQC ratings, a report about that. So, Shepherd, I think I'm coming to you for this.
Well, thank you, Debbie. You've got me. I suppose it's going to be a difficult one to follow such a direct impact paper on people, but I hope I'll try and bring that one out. Let me just get the paper in front of me. Okay. I'm really pleased actually to talk about these papers. I think some of the members may recall that about a year ago, we did submit a baseline paper on how we were doing in terms of CQC activity. So there are some changes to the paper, some additions that we've made in terms of actually producing a more integrated, trying to produce a more integrated paper to include dental. So really working on that journey to bring everything together. So you will find that there's more detail in the GP section at the moment, and there's also some indication about where we want to go around the dental services, so to try and bring those all together. I think I would go straight into the first table, because I would talk from the numbers, because I think that would help us to see the journey that we have taken from there. And I'm really pleased looking at the columns in there across the 5 localities at the moment, that we don't have any of our practices inadequate. And you may recall a year ago, we had about 5 practices that were sitting in that space. You can only imagine how much work has gone into that space to actually move or support practices to improve. So really positive. We are on a positive trajectory in terms of driving the quality of care and treatment that we are providing for our population. I will make a comment, probably I'll skip the requires improvement, because I want to give a bit of attention there, because I think that's where we've seen some movement going into. So if we look at the outstandings, apologies, I have to correct it, there are now 5 instead of 6. So there are changes with one of the practice that was inspected and has moved from outstanding to requires improvement. But we've got a very good action plan working there, and that particular practice is actually presenting some good practice at a national level, which is really strong. But we now have 5 practice. A point to make in that column is that all those practices were inspected a long time ago. So we would expect, with everything going on and with the changes taking place, with the focus on access and those challenges, those practices may be in a different position. But there's a lot of positive work going on across our system to kind of help those practices to be better prepared for the inspections. And that includes the work that LMC colleagues are doing in terms of working with CQC and ourselves to give all the information that is required to help with the preparation. I'm really positive to see most of our practice sitting within the good domain. I think there's a small change from last time. I think last year, a year ago, we reported about 92. So there's a bit of a shift into requires improvements. And in terms of the section which requires improvement, I think there's something that is not written there, but to note is that we've got a pattern on where requires improvement is coming in, and we know the areas that we need to focus on. We know that we need to build a culture of continuous improvement in the system, but obviously with some of the challenges we have around resilience, around workforce, we have to work through all that. And the focus on improving patient experience is also a great piece of work that is happening. There's a lot going on, and I hope at some point we'll get a chance to showcase the hard work that is going on in terms of supporting practice to improve patient experience. We're still continuously working on building resiliency from an understanding point of view, from a data point of view. So it's really a a lot of enhanced support going into those practices that requires improvement. And it's really good to also show that we've got dedicated resources, colleagues that from LMC actually supporting resilience, which we didn't have before. So we can only get stronger with more grip on this. And I think it's fair to say we are on a steady journey to actually demonstrate more grip around the activity and support that we are providing. I'm not going to go through the list of areas, quite detailed kind of summary of the areas where we need to improve. I think leadership is one of those areas, and we've continuously spoken about that. Then the governance, that is to be able to really follow through and maintain that discipline and consistency within a small practice is one of those challenges that practices that face. But we are more involved with the practices. So I really feel positive about where we are going. I'll just move you to the next table and just make probably 1 or 2 comments on the next table, which is really about the inspection dates. What you would notice there in terms of activity, before the pandemic, the level of activity from CQC was really very high. And that we have seen a 50% reduction in the level of activity since 2019. And the pattern really from 2019 is more or less the same until now. And the focus really has been, I think, in Norwich and also in West Norfolk and a bit of South. But North Norfolk has not had much attention from CQC colleagues. And you can see that some of the practices that are outstanding are sitting in those spaces. So really watching and working. Do you want me to stop? I can see a hand, or shall I just finish this? Then we can take questions at the end.
Yeah, just finished.
Just finish. Okay. So there are no really obvious significant variations from one place to another when we look at this data. I'm not going to make comments about the next table, but you've got all the information that you have there, and some of it I've already stated. And I just want to briefly move into dental without spending much time. I think what you have there is some information about dental, but the key things to mention is whilst the CQC are responsible for dental as well, it's not quite the same. There is no rating or numbers attached to it, but it's the same real things that affect people that are highlighted. So the rating is something else, but more importantly, I think the patient experience, effectiveness and responsiveness of services, leadership, they're still the same thing. So we should be able to demonstrate those in the future report when we report here. We are also looking to bring the pharmacy, whilst there's a different regulation, but we really want to surface the issues within our system and triangulate it and learn from all the service lines that we commission. I will stop there and take any feedback or any comments or any reactions, if it's okay.
Okay, that's great. Thanks, Shepherd. So Peter.
Thanks. Two quick bits, Shepherd. The sort of drop off in CQC activity, as well as seeing it across Norfolk, we're seeing it in particular in one area you were highlighting. Do we get an impression, is that a national issue, or is there something about Norfolk as well to do with the local inspection team capacities and things?
I can confirm that it's national. There is a change in approach in the way the inspections are being done, and also CQC are going through really significant challenges, just like ourselves. They have got staffing issues, and they're going through a major reorganization within the system. And probably they're still forming a new way of working, which they're still yet to understand. But at this stage, it's very difficult to tell whether we will see a change. But I can see probably this pattern being probably maintained for a bit. I think the positive news is that we are working closely with CQC. and the relationship is very strong. So we get to know almost everything that is going on in order to proactively support practices.
And my second point, actually, by coincidence, is directly linked to that, working with the CQC. I found really interesting the information under the dental part of the paper around collaboration with the ICB. So this may be about personal knowledge, and we can pick it up in our catch-ups outside of here. It may well be that the members of the committee are far better cited than me, but I would be interested to just get a headline of similarly how the ICB and CQC are working together on the GP primary care side, because as I say, I found that information under dental really interesting. But on the premise that the members are better cited, I'll happily pick that up with you outside of this meeting, Shepherd. Thanks.
Thanks, Peter. Karen.
Thanks, Shepherd. It's really good paper, and I think it's growing from strength to strength. And I'm really pleased to see that you'll be including patient experience as we move forward in the paper, because I think what we need to do is to understand any continuous improvement that we're seeing from the practices and the learning. And I think we really need to see any learning that's coming through from any harm. So there's a correlation of everything. So this committee has a really broad view of the triangulation of information. But I do echo, we have very good relationships with the CQC, which is really good, and obviously with our LMC colleagues. It is always about supporting primary care. So I'm really pleased to see this growing each time you bring it to committee. Thank you.
Thanks, Karen. Nick.
Yes, just to bring some background to this, I've had misfortune to be leading the profession at the CQC for about 7 or 8 years. And I rode into the pandemic period when the CQC's raison d'etre was putting their feet inside practices to have a look round, and suddenly, when they weren't allowed to, they didn't really know what to do. Now, that may seem as a bit of a problem, but actually it became a strength because they had to bolster their digital input. And I think that may be one of the reasons, Peter, why we're seeing a reduction in the number of face-to-face inspections, because the CQC have quite definitely improved on their ability to gather information from all sorts of different organizations, brokers, soft intelligence from various other things, that's helped them to identify those practices that perhaps need an inspection with feet on the ground. They can also harvest a lot of their information before they actually go into the practice, which shortens the inspection time enormously. So they're now beginning to start to inspect in a session rather than a full day, which is a benefit. The ratings has always been a problem because, as Shepherd's put in his paper, they only inspect 10% of practices, dental practices, in a year, which means that up until only a year or two ago, there were some practices that had never been inspected by the CQC because they were outside that 10-year period. And so if you have a rating that suggests that 1 or 2 of your areas are needing some sort of improvement or have failed, it takes you a very long time to wipe that off and get it corrected so that you are then, in the eyes of the public, a satisfactory practice again. So those are areas that we're working on. With regard to how do practices get their information, and I know that the ICB were working really hard to support practices when they were getting towards a CQC inspection. A lot of practices will employ companies to support them with all the information they might need. Most practices will do that now in order to be satisfied that they're able to at least have a fair run at a CQC inspection. So that's the background to it. CQC, as you say, Shepherd, are changing enormously. They're changing very much, and we wait to see how that pans out in the future.
Okay, thank you, Nick. Bill.
First, I'd like to apologise for my late arrival. I was at a previous meeting that overran massively, and I have to say Tracy was in it, so I've been swinging the lead. But on this particular issue, I've been interested in the recent CQC. So we know that there have only been 8. And what I don't know is the outstanding ones or all the requires improvement. So it'd be interesting to see what our trajectory is of the recent inspections has been compared to the snapshot, especially given what Nick's just been saying about people not being inspected for a very long time. So, you know, some of them must be very historic and may not even reflect the actuality of what's going on in the practice. So I'd be very interested to see, you know, how does our recent inspections compare with the inspections that we had, say, 2 or 3 years ago?
Yeah.
I'm happy to make a quick reaction to that. Just to say, Bill, the inspections that we have seen, there are predominantly follow-up inspections. So in terms of comparison, I think it may not be easy to compare. So maybe 5 of the 9 will be follow-up. So it's those that were inspected as inadequate or requires a really serious improvements, and we've been working with those practices. So that's where the focus has been. And I know that focus continues because there are still practices that requires improvement, and CQC are focusing on supporting those practices, partly because there is a challenge that practices have to go through when patients and the population feel that they are not doing so well. So it's being prioritized that way.
Okay, thanks, Shepherd. Nick?
Yeah, yes, Bill, just to give you some context for dentistry, nationally, up until about 3 years ago, 93% of dental practices satisfactorily passed their CQC inspection, but of late it's gone down to nearer 87%. We're not entirely sure what the reason for that drop is, whether they've got sharper pencils at the CQC or whether in fact we've got colleagues that are not quite achieving the high standards that they used to have. We're not entirely sure. But there is a reduction in the number that are passing CQC inspections in the dental practices. And bear in mind, it's not just NHS, it's the whole range. And I'm interested actually on that basis. Are the ICB interested in clinical dental technicians who provide clinical care in their surgeries? I'm wondering if that's an area where we aren't capturing a group of people that are providing clinical treatment within dentistry.
Okay, thank you. Just a reflection from me, if I may. So again, you know, echo what others have said about seeing this information in this way. It's really, really helpful, Shepherd. I still feel there is a piece of work that we could do that sort of maps by place, you know, CQC inspection. So, you know, if we see a crossover that says actually, you know, there's a high proportion of requires improvement of care homes, residential settings, etc., you know, we overlay that with these figures and everything. I just think that we should look at that and see what it says. And I guess my other reflection is that you know, I think those organisations where CQC has a role in coming in to inspect, we're all experiencing some challenges in their capacity. And, you know, we have in adult social services tried to encourage, almost said to CQC, you know, if you can't get to our places, can we fund you an extra team? You know, because actually the sort of the momentum and the sort of the value of getting people over the line when they've done a lot of improvement is really important. And I just wonder whether by looking at that in the round by a place, you know, in the future that might be something that as a sector, you know, we want to think about doing really. But I'll leave that hanging, and I know, you know, it's probably a nice to have rather than a essential, and I recognise how busy we all are. But I certainly think a picture of actually, okay, so let's map it and let's see what it looks like would be really helpful. Okay, all right, thanks very much, Shepherd. That's great. So I think I saw Okay, so now we've got a delivery report. So I'm not sure whether that's yourself, Sadie, or
Thanks, Debbie. Yes, if I just introduce and then hand over to Leah, who's done the hard work.
okay, thank you.
So I think we've been very conscious for quite some time that we haven't been able to provide an overall delivery report to committee. This has been one of the audit recommendations, and the work that our BI team are doing remains a work in progress in terms of a full dashboard for the committee. But I think what we thought was the very least we could do is to pull together initially our operational planning commitments that we have submitted to NHS England following receipt of the operational planning guidance earlier this year. And so that's what you see here, the specific metrics that the primary care team has been responsible for providing. So pharmacy first, although that's a bit of a work in progress because of the data reporting issue nationally, appointments within 2 weeks, and then new NHS dental patients measured separately for adults and children, and units of dental activity there as well. And it is important to note the little caveat around units of dental activity, in that the flexible commissioning guidance allows us to commission sessions now. So whilst we have this planning requirement, we're not necessarily, even if we were to be able to match the level of activity pre-pandemic, it would be quite difficult to demonstrate it through UDAs when we're taking a much more flexible approach to commissioning as set out in the national guidance. Then we also have our severe mental illness health checks and our learning disability health checks. You'll see in the appendix there's the actual data, the trajectories, and each time we bring this to you, we will have completed the actuals as far as we can there, so that you'll have those. And at that point, I would like to hand over to Liat.
Thank you, Sadie. Thank you, and good afternoon, everyone. As Sadie said, this is a first attempt. So as I gain more data and work with BI, hopefully the reports will be able to provide a better understanding of where we are in terms of patient access. So any feedback will be greatly appreciated. Just want to highlight that we've got our first batch of Pharmacy First data, and that shows 1,584 appointments were made, which was incredible. And the other thing that I just want to really quickly highlight is that this quarter was the first time we almost hit target with SMI health checks, and we were 1% away from meeting national target for LD. So that's incredible as well. So thank you.
Okay. Questions or reflections? Han.
Yeah, thank you, Sadie and Liat. I'm really pleased with this, as Sadie will realize this, because I've been like internal audit on Sadie and colleagues' case, because I think we're sometimes doing ourselves a disservice in primary care by maybe not highlighting some of the rich data that we sit upon, but maybe not always can get to the surface. So I'm very much welcome this delivery report. It will mature over time. I have no worries about that. My only request really is to not just produce numbers, but sort of the story behind it, because I think that will really help the committee. Because you could say reaching nearly 600,000 appointments with GP is a great thing, and maybe it's not a great thing at all, if you know what I mean. So there's always two ways you can look at these things. Last thing, I've been in contact with people working on learning disability in the BI team, and I believe they're on the cusp of really getting very rich, and to Debbie's earlier point, sort of place-based metrics, which I think will really enrich our understanding. So well done. Looking forward to future reports. Thank you.
Yeah, thanks, Hein. Bill.
Yes, thank you. I just wanted to echo everything Hein said, and I agree with everything he said. And I look forward to where we go with this report. I just wanted to pick out the learning disability. You know, we're nearly there, 1%. We've come from a long way behind on that, and I think it's lovely. I was concerned that we would see an improvement, but then a tailing off in performance, and the fact that it is sustained, and that is the and so I really just wanted to say, in well done, Shepherd and the team. It was something that's taken a long time, and I'm pleased to see that we're maintaining the performance, and look forward to us getting to target.
Yeah, brilliant. Thanks, Bill. Thank you, Peter.
Thanks. Mine's on the data, so I don't want to dig into it here, but it's just to say I'm sure the explanations are clear to the people who wrote the report, but it would be helpful to have the occasional footnote. So, for example, the appointments on the first set of tables at page 62, the appointments in general practice at 621,000 are lower than the appointments seen within 2 weeks. That doesn't seem to make sense to me on the face of it. And then at the last set of tables at page 64, the denominator of resident population registered with any GP is 913,500 in the first table and only 188,000 in the second table, but the denominator statement seems to be the same. And my third bit is, actually, it's going back to an earlier table, apologies. My third bit is, in the appointment scene, I can foresee a question that says, what's your definition of scene? And I'm particularly mindful of the whole discussion about face-to-face versus e-appointments versus telephone, etc. So scene, you know, I can just foresee a question in the future of what does that mean? Thanks very much.
Okay, thanks. Shepherd, do you want to answer what you can of those?
I wanted to make a separate contribution,
Okay,
but
fine.
that one I will probably pass.
Okay, go on. You go ahead.
I thought I would do. Oh, Sadie probably wants to react to that one.
Sadie,
Yeah.
was it in
Yes.
response to Peter? Yeah.
Yes, thank you. So we will take most of your comments offline if we may. The 2-week rule, these are the definitions given to us by NHS England rather than our own, but essentially it means that if somebody needs an appointment, regardless of whether it's face-to-face, in the majority of circumstances, they would get those within 2 weeks, and that's what it means.
Okay,
We'll clear everything else up for the next report.
Thanks, Sadie. Thank you, Shepherd.
Thank you, Sadie, to my rescue there. Right, I thought it would be a disservice to the learning disabilities and mental health community if I don't make comments, because a lot of hard work has gone into this. I made a commitment that I would like to raise the profile for people with learning disabilities and mental health. And I'm really grateful that the delivery report did not miss and forget this population in there. So thank you for that. But I wanted to assure the committee that we are no longer an outlier in the system. In terms of the numbers and in terms of quality, we are more stronger on quality than probably many other systems. And I can confirm that we are not doing our annual health checks via telephone calls, like I'm not going to say like other regions, but I think we know that in other regions, some of the challenges they're facing is that the annual health checks are being done. Whilst we are reporting a percentage short to the target, we genuinely believe in the system that if our data, we have hit more than 75% because there are some practices where the national errors in the data are still yet to be corrected. So we've seen a significant increase in the register size, about 50%, in some cases by 70%. Whilst the national team are very clear that the registers have been corrected, but we know that that is not the case in our cases. So yes, we accept 74%, but we know we've done more. And we know that we are set for the following year. And I think we have it for the following year. So I just wanted to say those words for the population of our community. Thank you.
Thanks, Shepherd. Nick.
Yes, a quick question. I think the metric looking at new dental patients seen, both children and adults, is really, really important because it highlights to us whether things are beginning to improve. Now, it might well be that if the pot is completely full and we're seeing new patients, it means it may be at the detriment of existing patients. But my question was, how are we measuring new patients? Are these the patients that haven't been seen in the previous 24 months?
Yeah, I believe so, Nick, and it'll come through to us in the usual way through the Business Services Authority.
Yeah,
data.
exactly.
Yeah,
exactly. Because that's a new measurement, and dentists are being paid now according to new patients that haven't been seen for 24 months. So it should be an easy piece of data to capture, provided they're being seen, as you say, within a UDA system rather than a sexual system. Thank you.
Okay, thank you. As always, data, we go, oh, we want data. And then as soon as we get it, we have 101 new questions because that's the nature of data, isn't it? It's only ever, a starting point, really. It's never the answer. But thank you, team. It is really good. And I think the number of questions you have shows the appetite to, get our teeth into this. I think it's really good. I mean, from my two penneth worth is, at key points in the year, I'm pretty sure I've seen here sort of benchmarking national comparisons. Pretty sure you've brought that to a meeting here of looking at how many GP appointments there are per head of the population in other areas compared with here. Again, I think anything that at the right point in the year that gives us that sense, I think is helpful as well. But really great to see this. So thank you very much.
Thank you, Debbie. I was my next report, I think I'm going to put the national.
Yep.
I just wanted to give everyone a flavour first,
Sure.
and then I'll get into the story and stuff.
Okay, that's lovely. Thank you. Bill. Bill?
I'm sorry, no, I don't. That must be a mistake on my part.
Okay, fine.
Sorry.
All right. Okay. We've got some summary sheets there about the access improvement. Is there anything anybody wanted to say about those, or are they there sort of as backup on the other stuff as well? Sadie?
Yeah, so these are the highlight reports that Liat's been working with Leeds on. Very happy to bring these, send them out on a more regular basis outside of meetings. We just wanted to bring them here as obviously some of them are more work in progress than others. But if members would like to see these on a regular basis, we're very happy to share them in between meetings.
Yep. I think the answer is yes. I think that would be great between meetings. I know members of the committee are genuinely sort of interested in, the progress in between and what you're doing and the more detail. So please, yes, that would be great. They're very clear and, really get to the heart of it. So they're very helpful. So thank you. Okay, marvellous. All right, well, thank you very much. Let's move on. I think I saw John in the room at some point. So John, I think you're going to take us through the most recent sort of complaints and inquiries report for primary
Yes.
care.
Yes, that's right. Thank you, Debbie. And for those of you that don't know me, my name's John Punt. I'm the ICB's Patient Experience Senior Manager. I kind of almost assumed that I'd take the report as read, but what I've tried to do in that report is just to succinctly try and capture what's going on in terms of the amount of contacts the ICB's received across the financial year, which, given the numbers of contacts and the variety of issues that have come in, was no easy task, actually. But I thought there was just a few bits that I wanted to highlight. The first is the actual volume of contacts. So the number of formal complaints that we actually received across primary care services was way in excess of what had been given to us in terms of indicative numbers from NHS England. So NHS England perhaps anticipated that we'd be looking at between 150 and 200 formal written complaints per year. We got 221 over a period of 9 months. So if we extrapolate that out across another quarter, you're probably looking at getting on for, you know, what would have been 300 across a financial year. But what we also didn't anticipate, and there was, I don't use the word deluge lightly, but I think it felt like a deluge at the time, is that there was an anticipation that the non-formal complaints, if you like, the kind of informal concerns, queries, just questions that came into the ICB, there was an anticipation that actually they would continue to be handled by NHS England's contact centre for a period of weeks, months, or even years. And in reality, that didn't happen. So there was nigh on, I think it was 960 something, but there was kind of nearly 1,000 additional contacts that the team received, which again, you know, kind of made it quite a challenging year to deal with all that. But it was actually really positive in terms of it meant that we were forming relationships with practices, certainly general practice quite a lot. You know, we were on the phones to practice managers trying to get early resolution to a number of concerns. So a really challenging time, but it was actually really informative and welcome. In terms of what the contacts told us, I don't think it's any surprise, you know, to anyone in the room that actually access to dentistry was a massive issue that people were bringing to the attention of the ICB, as was access to general practice. So that featured heavily. And it was, you know, typically people saying either, one, I can't get a dentist, what can you do to help me? Or two, I'm in, you know, kind of real dire need of emergency dental treatment, what can you do to help me? Now, the advent of the emergency treatment service, you know, kind of took the sting out of a number of those inquiries. But again, given the finite capacity that was in that system, there were still people coming to us once the pilot had gone live who were looking for assistance to try and navigate their way into the service. In addition to that, there was quite a lot of people that came to us, and this is detailed a bit further in the report, who were struggling to get access to their GP practice. Now that could be they can't get through on the telephone, they can't get the type of appointment that they wanted initially, or a number of other issues around communication from the practice. And that was in addition to something which actually surprised me quite a bit. Not a number of people raising that they didn't really know how to complain about their GP practice or dental practice, and so they'd come to the ICB as a result. So that's something that I think maybe we need to reflect on as a team and just see if there's anything that we can do to support primary care to make sure that there's really efficient and informative complaints information in the public domain. The kind of last thing that I wanted to highlight was, and this has surprised me because it's the first time that we've been handling primary care complaints within the ICB, was the kind of habitual and I'd call them perhaps more aggressive complainants or inquirers. And whilst the number of those has been much lower than perhaps, you know, kind of the more regular contacts, actually what's really surprised me is some of the behaviour of patients or members of the public towards either my staff in my team or towards, you know, practice staff as well. And actually it seems that there's a real step change from perhaps acute complaints or community service provider complaints and primary care ones. I just thought it's something that's worth highlighting here, is that actually that, coupled with obviously the incredible pressure that's on primary care at the moment, must make it a really, well, does make it a really challenging landscape. But yeah, so they were the highlights from me, but I'd welcome any questions that you have.
Okay, thank you. Lisa.
Hello there. John, it's a very good report. It did tie in with some of the things we are having reported to the LMC too. I note that there has been a number of concerns raised by patients who are expressing their dissatisfaction with actually not seeing a GP, seeing other clinical team members. We understand that the ICB has previously publicised the different clinical roles in the past and the ER staff. Could this be reviewed and, where necessary, updated and reshared appropriately, and where it's publicised? Because a lot of the feedback we're receiving from general practice is that people, staff are finding it extremely difficult to handle patients, etc., because they don't often understand these roles. So is that something that could be looked at? Because I feel that would also help the staff in general practice itself. Also, the roles themselves, if there's full explanations, and even if that's shared with the practice and the practice can communicate that out too through their own PPGs, etc. I know you've done it in the past, but I think this needs to be reviewed because there's also been additional roles added to the R scheme. I also noted that you done complaints training in July last year. Is this something that you're looking to do again in the future? Because I feel that would really benefit general practice too.
Yeah, I mean, I can talk. So probably the training is the one that I'm most qualified to talk about, Lisa. So if I can touch on that now. I mean, the quick answer to that is yes. I'd be really happy to, and conscious that actually formal complaints or any type of complaints aren't necessarily practice managers' specialisms and just a really small part of their jobs. So if it's something that they'd want done, in a bespoke way, so that I could perhaps go out and see, primary care network, or if it's something that could be done virtually and offered out to all, kind of a general practice at the same time. I'm really not fussy, but if we can identify a need, so if there's really specific things that they'd like to look at or just like to cover, then yes, I'd be really happy to.
The LMC would be happy to support you with that and support training. We're looking to do bite-sized sessions, so something we could perhaps look at as well. Brilliant. To support you.
Shall we touch base, kind of outside of this meeting, Lisa, and perhaps see if we can get something organised?
Yeah, that'd be really good. Thank you.
Great.
Thanks, Lisa. That's great. Thank you. Andrew.
Yeah, John, just to say, I hear about a lot of complaints from doing GP appraisals and passing the appraisals to go through complaints. And I must say, my impression, certainly my personal impression, is that nearly always is it communication failure or lack of continuity, but hardly ever is it a purely clinical matter. Occasionally it is, but not generally. And really what we've got to do is learn from these complaints, not turn them into a blame game, but learn from them. And the second thing I just wanted to say is to go along with Lisa in that the explanation of the additional roles, I know it was tried a year or more ago, and it was mainly on internet-based methods, so tweeting out messages and so on, which is to people who are already following the ICB on Twitter, and therefore doesn't reach the bulk of the general public. So I do think there's a communication gap on the way that all the additional roles work together and form a team. And I absolutely know that from talking to people on the ground. Nobody understands this, apart from those of us who are involved.
Okay. Someone else has got a hand up and I can't see it. One moment.
I think it's Karen.
Karen was next, yeah.
Thanks ever so much, and thank you, John. Really good report, and I know how busy your team are, because we quite often have regular correspondence about a variety of things. So we do work hand in glove in terms of quality and complaints. I guess it feeds into a little bit of the so what question, doesn't it? So what has changed? So one of my questions is, what's changed as part of some of the complaints? So in terms of learning, recommendation, and I know we've talked about webinars, perhaps in the future learning from particular incidents. Is that something we'll be able to incorporate as we move forward with this report?
Yeah, so it is in the report, Karen, in terms of like general practice and the dental stuff, and there's some pharmacy stuff. So what I've tried to do, and perhaps I should have talked about it up top, is just highlight against each of the individual disciplines, you know, within primary care, actually some specific lessons that we've learned. I think what we need to consider moving forward as a system, and actually the fact that my job role has slightly changed, and you heard at the start, I'm no longer complaints manager but patient experience manager. I think some of that actually is about talking about the so what as a system rather than the so what as an individual practice, and that's what we need to, I think that's what we need to get better as an ICS and you know, as an ICB leading that particular process. But we're very much, you know, given the organizational restructure, you know, we're very much in the infancy of that work, and I think we need to scope out and perhaps come up with a strategy around how we're going to do that as a system. So sorry, I'm rambling a little bit there, Karen, but hopefully that answers your question.
Thanks, John. Thank you. Bill.
Yes, thanks. I wanted to welcome this report, and I know, John, you've had a very busy year, but I think that it has been a sort of complaining about issues within it has been a bit of a dark art before, and I think that the fact that we're shedding some light in this area, and you know, the report's coming to this meeting, and in a way, the fact that you ended up with all of the original NHS complaints coming through to the system, I think was, as you said, was probably a good thing. And I, you know, I'm not worried about how high they are now, because we had to start somewhere, didn't we? And really pleased with that. So, you know, I welcome the openness of where we're going, and you know, you've just spoken about where we go once we you know, where we go in the future with what we learn, and that's really encouraging to hear you talking about that. So I absolutely support that as well. But I think this you mentioned clarity of how people complain, I think would be important, but also it's going to be helpful for us to be able to compare apples with apples going forward. So the quicker that we make this clear, then we're not going to be sort of underreporting in certain areas because they're going to the wrong places, and so that even though we're dealing with it, it looks like the situation's deteriorating as people become more aware about how to complain here. So I'm keen that we should have an opportunity to establish, you know, a baseline in the next couple of years. But you know, congratulations to you and your team, and really pleased to see this report.
Thanks, Bill. And I think there's probably another point in there whilst you were talking, and it's not something that's fully reflected in the report, is that this is purely the contacts that the ICB has received. So actually the vast majority of complaints or concerns about primary care services do go directly to the provider. So this is real tip of the iceberg in terms of what this is telling us. And part of my thinking moving forward is, how do we actually capture everything that's going on at the coalface in primary care in terms of the complaints that are being handled there, so we can bring that back in a uniform way to the ICB and the ICS in a wider way to share that learning. And I would very much welcome ideas, and you know, kind of if there's anyone in the room who'd like to discuss it further around how the ICB can work with contractors around that, then yeah, it's definitely something we need to get better at.
Okay, thanks, John. Thank you. Nick.
Yes, John, thanks very much for this report. Just for your information, I'm dental advisor to the PCCC. One of my hats previously was that I sat with the complaints team at NHS England for the Eastern region for dentistry, so I'm familiar with the tsunami of complaints that came through. Clearly, a lot of the complaints that you're dealing with or inquiries are to do with not being able to get a dentist, so it can't really be resolved at a dental practice level. But one of the issues, and I'm wondering whether you can support me on this, is that patients very often didn't realise that they should go to the practice first to try and get their complaint resolved, and actually went to NHS England, or in your situation, the ICB. Once you've got that complaint, am I right in saying now that you can't send it back to the practice to be resolved, but it has to be escalated after it's been dealt with at your end to the commission, to the complaints commissioner?
So I guess that's a tricky one to answer, because what we'll try and do is take each case, each formal complaint, on a case-by-case basis and try and discuss with the complainant actually what's the most appropriate way forward. So if for example, you know, in the scenario that you're describing, we receive a dental complaint into the ICB, we'd have a look at it, and actually if we feel that it might be best handled by the dental practice themselves, and actually it would be a better outcome for the complainant if that happened, we'd probably try and get on the phone to the complainant, or, you know, have a meeting with the complainant and discuss this with them and just see if they'd be open to that. Because if that's a better outcome for everyone, then you know, with their permission, we would try and facilitate that happening. However, there are some complaints that come to our attention where there might be things that are slightly worrying or troubling in there, and actually we feel like we'd want to front it, you know, as Commissioner of Services, and so we'd retain it in-house. So there isn't really I often say to my team, you know, there isn't a standard way from A to B, and it's making sure that we make it the most efficient, you know, kind of use of the journey in terms of, you know, the complainant and bearing them in mind. But yeah, so maybe Bill describing it as a dark art previously is probably right.
Thanks, John. Lisa.
John, you said in respect of being the tip of the iceberg, each individual practice will have a complaints log with the number of the complaints, types, etc., because they have to keep that for CQC. And likewise, they will also, most practices will always have it for compliments too, because you've got to weigh up the fact that it's not always negative in general practice.
Yeah.
So you would, if you requested that data, practices would be able to give that to you.
Yeah, and that's something that I had in my head, Lisa, because actually there's been a couple of practices that we've supported to give them kind of sample logs or trackers, so that, you know, they can record their complaints in a similar way to ours. What I'm just thinking at the moment is, and this was part of what I was anticipating over the next few months and years, is that every practice probably records their complaints ever so slightly differently, and if we can get everyone doing it in a uniform way that, you know, that comes back to us, it's probably going to be a lot easier for myself, or, you know, people analysing the data to what's the best way to put this, to work out what the rest of the iceberg is telling us.
Yeah. Okay. Thanks, John. So Lauren wanted to come in.
Yeah, I was actually going to say what Lisa said actually about community pharmacy, is that our pharmacies are required to produce an annual complaints report. However, I'm not sure they would actually know where to send them at the moment, because it used to be the regional team, and then we've obviously got local delegated contracting, but our national body still says to send them to the regional team, who do obviously have a role in this. But there is a set data set that they are meant to submit, which may be helpful to you in order to compare apples with apples, so to speak.
Thank you. Yeah, I'll bear that in mind. Thank you very much.
Sarah. Sarah, did you want to come in? I don't know whether you're having trouble with your microphone. No? Okay. Sarah, if you are trying to come in, then put something in the chat if your microphone is difficult, and we'll see if we can come to you. Okay. Thank you. That's great, isn't it? And again, you know, it's one of those areas which is so important to look at and generate, you know, lots of questions, lots of interest, John. So thank you very much. I guess at some point, I do think it's worth picking up and thinking about the point that Lisa made about, you know, people wanting still to see my GP, and how as a system, we try and sort of turn the curve on that. I mean, we're trying to, I sort of think that it's not just one for this ICB, it's a you know, a whole nation issue, isn't it? And effectively we're trying to sort of suddenly tell people, well, you know, for the last sort of, you know, 70 years we've been telling you your GP is the most, you know, the key person, phone your GP, do this. Well, suddenly we're saying actually, oh no, actually you don't need to. So, you know, there's a big piece of work there to be done. But you know, maybe we need to think about at some point how we use the networks we've got to begin to do that. With the best one in the world, I think putting out tweets, you know, isn't going to reach the people that we need to. It's when you know, it's who tells you those things and at what point you hear those things, and some analysis around that might enable us to do some work, perhaps in that, because I do think it's an important point to support practices really, but maybe we can think about that offline and come back to that at some point. So, John, thank you so much. I don't know how you keep smiling, but you do.
All right, I'm just going to go and get some booze now, Debbie.
Yeah, all right, fair enough. Okay, you've answered my question. All right, okay, that's great. Thanks very much.
Thank you.
So I think on the agenda now we've got the reports from the delivery groups. I don't know, Sadie, how you wanted to handle those, whether people wanted to speak to them or whether there were specific issues that we needed to note or you wanted to highlight in those.
From my point of view, for general practice and community pharmacy, I think it's a fairly standard report this time, but quite happy to answer any questions on it if people have them. I think we've got, oh yes, I can see Will now. We've got Will for dental,
okay,
as well.
Yeah, Sadie, I echo those comments. It's obviously for noting. The only one escalation to PCCC was discussed earlier in the meeting, which was the secondary care risk that Sadie outlined. So, yeah, I'm happy to take the report as read and any questions anyone has for either of the reports.
Okay, all right, thank you. I mean, I think just to acknowledge that, you know, this is so helpful to see this in this summary way, and allows this agenda to sort of you know, focus on perhaps the more sort of you know, ICB wide issues, etc., and the more strategic issues. But this is really invaluable. So thanks to those who pull them together and keep this work moving. Shepherd.
I know it's written down, but I just want to highlight it. The good news story for Matisho and Lenwood, because it was really good to hear it at the operational delivery group. But because it takes a lot of effort and time and commitment from colleagues, I really think that we need to shout it louder in this space. So they moved from inadequate to a good rating, and I just want it to be noted, and well done to the practice.
That's great. Yeah, thank you, Shepherd, and thank you for highlighting that. I have no idea if this is appropriate, and I'll leave it to you guys, but you know, to sort of acknowledge that on behalf of the committee, I'd be very happy for a message to go to those practices to say that, you know, it's a great achievement and we really value that as part of the overall improvement programme for primary care. If that's appropriate, I think that'd be great. Okay, anything else any colleagues wanted to highlight on these reports or any questions? No? Okay, all right, well, thank you very much. Thank you. So that takes us on to the money. So Rashmi, welcome. I'll leave it to you to take us through these slides. Thank you.
Firstly, good afternoon. For those who don't know me, I'm Rashmi and I am the Primary Care Finance Manager. I'm here because James is unavailable today. So basically, I'm just going to explain what our finances were as of March 2024. That means for the financial year 23-24. These numbers are not yet audited. So they are subject to audit. And I'm assuming that you all have read all the slides which were presented in the PCCC packs. You might have noticed that we have changed the format of reporting to make it more user-friendly. And basically, the main highlight points here are that, we have an annual budget of approximately £556 million, which is shared across primary care and GP prescribing. And we reported a favorable variance of approximately 10 million, which means our actual spend was about 546 million. Now we have a few graphs in the slide in the slide that we have put in the packs to make it more user friendly, and you can see that the main there were some adverse variances in GP prescribing, in LCS delegated, Optom and pharmacy, and oxygen, but they were offset by underspend in dental area, and we had some non-recurrent slippage in mitigations. And that was the result because of which we had an favorable variance of 10 million in the 23-24 financial year. The next slide explains the different areas where the underspend or the overspend was, and it also explains the reasons why they were what they were. So the reasons are given in the slide in the packs. Then we have the next slide, which is basically trying to explain the primary care and prescribing spends as they fit in the whole of the ICB. So the ICB finance has got different directorates, example, acute, community, then you've got mental health, continuing healthcare, and different directorates. And we have a huge budget of approximately 2.4 billion. So where primary care and prescribing fits in those budgets, and what was the underspend or the overspend in all the other areas of the ICB, both in pounds and percentage times, was shown in the other slide. Then we have the prescribing efficiency slide, and this slide you can see that we started with an 11.1 million savings target, but we achieved 9.6 million, but still that is great because the target was really huge. And so there was a lot of schemes in there, and the list of the schemes and the variance reasons are also given in those packs. Then moving on to LCS activity tracker. This explains all the schemes which are under the LCS heading. And I think there was a request in the last PCCC meeting to discuss why diabetes scheme was overutilized. And the reason for that is that because there are key care processes and treatment target elements of diabetes, and that is the reason for the overutilization. And there was also some comment about why the mental health SMI health checks are underutilized. And the reasons were that there is a GP staff shortage, but it seems there are some new QOF indicators because of which there would be more utilization of these schemes. And then the final is naturally the appendix, which explains all the different areas of primary care and prescribing, what the annual budgets and the actuals came out, and the variance as well. So if you have any questions, I'm more than happy to take it. But if I don't know the answer, I will take the question and try to reply later.
That's great, Rashmi. Thank you. That was very clear. I like the waterfall diagram at the front, I must say. Okay, open it up. Questions, comments? Hein.
Rashmi, thanks. Excellent explanation of the pack. I think I was one of the culprits who asked about the LCS activity tracker, and not so much for now, but I think again this is a useful overview to bring back maybe as part of the quarterly reporting we get, because I'm still interested. What are some of the underlying themes, for instance, on diabetes, PSA? We heard earlier in the meeting SMI health checks have achieved their target, or more or less the target, but there's an underspend here. So how do the two match up? So not so much immediate action, but maybe for a quarterly update report that we see some of the underlying trends, because I think it would be helpful for a committee to see that. Thank you.
Absolutely, absolutely. Thank you.
Sadie.
Might be able to answer the SMI question straight away in that in order to count as, and I'm looking at Shepherd just to check that I'm saying the right thing, but there are two different elements to the SMI health check. There's the kind of standard core health check, which has a number of indicators within it, and there are some additional indicators for gold standard, and our LCS funds the gold standard bit because the remainder of the check is incentivized through the QOF, the Quality and Outcomes Framework. So what we might see is that in terms of the number of checks undertaken, you have one level, but do they have the enhancement to them that would be claimable under the LCS? Maybe, maybe not. And I think that's why we see the slight difference in the figures.
Okay, thanks.
Thank you.
Okay, get the order right. So I've got Shepherd next. Oh no, Peter, sorry, apologies, Peter.
No problem, no problem. Apologies if I'm sort of stating the obvious, but on the finances, that the ICB, or that this part of the ICB came in at circa 10 million underspent, it is predominantly to do with the slippage in dental. Given all of the work that's now happening with dental, I propose that we can't be as confident that there'll be similar slippage again in 24-25. And I guess, you know, the irony of the success in dental will be that it will immediately, you know, remove what was the balancing factor in the overall spend in this area over the 23-24. And so I guess, again, to state the obvious, but I guess there's something around the so what to that, you know, what happens in 24-25 that achieves the balanced budget again, or even an underspend again, given that we actually hope to turn around the dental position. Thanks.
Yes, I can see what you're trying to say there. We have submitted the plan for 24-25, and so we are prudent, and naturally we don't want our people to suffer for dental. So there is no such, as far as my knowledge goes, we don't want to underspend in that area. There is a plan which has gone in, so we are quite prudent in what we are doing. But we are monitoring it on a regular basis. So whenever the next meeting happens, we will again monitor the position. So we also have the GP and the dental operational delivery group, in which we do present the finances regularly. It could be monthly, bi-monthly. So you will be seeing the dental position there in 24-25 finances.
Okay. Thanks, Rashmi. Shepherd.
I just wanted to follow on Sadie's point around the SMI, but to draw the parallel with the diabetes, because I just want to assure you, Hein, our interest in diabetes in terms of the actual activity and the outcomes that we are gaining from that area is growing, and we will see more in our next reporting. We have got some variations across our places in terms of people being seen or receiving the checks that are related into that space. So really exciting to be reporting next time when we get to that. It's got a similar pattern with SMI in that there are shared processes, and not all of them sometimes are being completed. So it will be interesting to also layer out that with the finances, because it's overperforming. So if we improve the data, what does it mean? Are we going to see more overperformance in money? So there's a piece of work that we're doing to make sure that we've got a good grip in that space.
So I've got Nick and then Sadie.
The element of the dental budget within each ICB has varied in as much as some ICBs have ring-fenced the dental budget, so it has to be used for dentistry. I don't know what's going to happen after July the 4th, but it's something that might occur, that the dental budget becomes ring-fenced rather than being available for any use if there's an underspend. And the other question I've got is over the jargon that's used within finances, and I just take you to you talk about an 18 million favourable variance in the dental budget, and I'm just wondering if favourable, if these are publicly facing documents, whether favourable is a word that the patients might understand as being perhaps pretty unfavourable, and I'm just wondering if there's a different word we could use for that underspend rather than favourable, because it immediately stood out to me as, oh, crikey, you know, we would like to see that all used up. It's not, if it's favourable to the ICB, it suggests that there's an effort to try and keep as much money within the ICB as possible, which I know is not the case, having worked with the ICB for a while. I'm just thinking maybe the jargon might be tweaked a bit, possibly.
Can understand, definitely it's an underspend. It's not favourable. It's an underspend.
Okay, thank you. Bill, and then, oh, Sadie, did you put your hand down? It's been covered. Okay, Bill.
Yeah, no, thanks. Rashmi, just looking at the where it says the ICB financial position, we have pharmacy, GP prescribing and other prescribing costs in the primary care and prescribing reporting. So in our table about what primary care costs, it's in there, and the total is 556. And then we go to the ICB financial position, and we have the acutes with 1.2 billion in one line. But for some reason, we have prescribing separated out from primary care. And I just wondered what the reason for that was.
Yes, the main reason is that GP prescribing in itself has got a significant budget, and the requirement for monitoring that budget separately has been identified. So we separate, when we report it, at that time we report GP prescribing as a separate line, and the normal other primary and the other primary care, which includes delegated and the DOP areas like dental or optom and pharmacy, etc. We combine all of them under the broad heading of primary care. That is the reason why we have separated both of them.
But we don't with the acutes. I just wonder, because it's not as big a number as the others. You know, either it is part of primary care, and therefore, because it's reported elsewhere, but it's not, you know, this seems to be more of a political decision within the ICB. I mean, it might be irrelevant, but I just wondered that sort of scrutiny, and you know, there are cost pressures elsewhere within the system and much bigger figures. If we look at the acutes, none of that's been stripped out for the purposes of this sort of reporting. So I just wondered why prescribing in particular above all the others has been pulled out. Because, I mean, yes, because we're looking at the variances, but we're doing that within primary care, and it's reported in the slide before, where we're going through the primary care and prescribing reporting.
Well, the audience for this meeting is for PCCC. So that is why we have kept the acute area, the community area, all those as one single line, because if we go on explaining those, then that becomes an irrelevant information. But we just wanted to add this slide in order to explain in the context of grant schemes where primary care and prescribing fit in the bigger budgets of all the other areas of the ICB. That is why.
Thank you, Rashmi. I think that's very clear. Thank you very much.
Thank you. Stephen.
Yeah, thanks, Deb. I just wanted to come back to Nick's point around the dentistry ring fence. So it's not an option for us. It perhaps was last year. I think the ring fence was relaxed, but as we go into this financial year, 24-25, it is very much ring fence. That's been made very clear to us. And as Rashmi says, we're monitoring that really closely. We have plans to spend some of that and wouldn't anticipate an underspend similar to what we've got in what Rashmi has reported there. But just to be clear, there is a ring fence in place at the moment, but obviously subject to 4th of July, of course, but there is a ring fence at the moment.
Okay. Sadie.
Sorry, Debbie, it's not a point related to this paper. We've just skipped over an agenda item. So when you finished this item, would we please be able to go back and do the pharmacy and Optom paper?
Yes, of course.
Thank you.
Yeah, thank you. So I think we have done the finance. Rashmi, thank you very much.
Thank you.
Very clear. Helpful to have that end of year position like that. So thank you. So apologies. Let's go back. So this is, oh yes, agenda item 12, is that right? Yeah, great. Okay. Sharon, this is you. So hopefully you haven't.
No, I'm still here.
Good, thank you. Sorry about that. Over to you.
No worries. It looked very similar to the previous paper. Yeah. That's probably why it was linked together. It's very brief, really. So obviously both these papers are bought for noting. I will just separate them out into a pharmacy paper and an optometry paper. Just to give some people context, I'll just start with the pharmacy paper first. This is in relation to decisions made at the Pharmacy Services Regulation Committee, and as I will call them, the PSRC, because that's a lot easier to say, between the January and March of this year. Just for a reminder, the PSRC is a committee which is brought together or formed by all 6 ICBs in the east of England. It's responsible for making decisions required by the NHS Pharmaceutical and Local Pharmaceutical Services Regulations 2013. Their main role is to consider market entry applications and for secondary to consider and review fitness and matters of concern. Also, for certain applications, the committee will consider the information which is published in the Health and Wellbeing Board's pharmaceutical needs assessment. Each Health and Wellbeing Board is required to publish a P&A every 3 years. Just to highlight in terms of this report, one thing that was pulled out, so the market entry decisions are made at the PSRC meeting. Any decision that is made is applicable for an appeal by interested parties. So although we may not see any appeals in this paper, some of these may be subject to appeal, which will probably appear onto the next paper. One thing to note, and I found quite interesting, was an application, bearing in mind that our P&A states that there is no gaps in pharmacy provision currently at the minute, but is due for review next year. And we did have an application that was granted with unforeseen benefits, and that was at the University of East Anglia. As I say, because obviously appeals can be made against this application, it doesn't necessarily confirm that a pharmacy will open in that location, and any appeals will be made through the NHS resolutions. In terms of the paper, I don't believe there's anything else really for noting in terms of committee members to highlight, but I can take questions on the pharmacy element of this conversation if anyone would like to raise anything now before I move on to optometry. No, we'll head over.
Yeah.
So
had an optometry paper presented at PCCC. Again, this is just to highlight the delegation of the general ophthalmic services, or GOS as we all call them, was again delegated out to the Herts and West Essex team in the east of England. They managed the GOS contracting function on behalf of the ICBs, or all 6 ICBs in the east of England. GOS contracting, in summary, just so people are aware, is the provision of NHS site tests to eligible patients, either from a fixed premises, which are mandatory service contracts, or from a patient's usual place of residence or a day centre, so potentially care homes, and they are called additional services contract. The contracting aspect of the NHS site test is the only element managed by the contracting team. All other healthcare services are commissioned by individual ICBs, but obviously from a primary care function, it is the GOS site test and the optical vouchers, which is the only thing that we cover. So I just wanted to give some context in terms of what the GOS was, what that related to primary care, but I think the rest of the report is easily read and understood. But again, if anybody would like me to highlight anything further, I'm happy to take any questions.
Goodness, another area where you know there's just so much to learn isn't there, about this. And I do remember we did have a great discussion a while ago about optometry, and you know, it'd be really good to come back at some point to that. So I don't think there are any specific questions on that, Sharon, but thank you for the reports. They're very clear. So thank you very much.
Thank you.
Okay, so I think that now takes us then back to the prescribing report. Michael, welcome.
Thanks very much. I'm not on mute, am I? No. So prescribing report, we're moving towards a more strategic report, and this is possibly my first stab at that approach, rather than quoting numbers and performance and spend and cost pressures in prescribing, looking at the key things within strategic use of medicines. So medicines, some of the data in there suggests they can and do cause harm. So 1 in 7 hospital admissions are due to medicines, and 1 in 20 are due to medicines and are potentially preventable. So the ways that you can prevent some of these occurrences is by doing appropriate monitoring and reacting to them. Doesn't always give you the full picture, and also doing structured medication reviews. So inviting appropriate patients in to go through their medicines and consider side effects. So look at polypharmacy, which is purely a phrase for patients on lots of medicines, and one of the benchmarks is more than 10 medicines, 10 regular medicines. And as you get older, and as you're on more medicines for more conditions and you're more deprived, the more likely you are to have adverse drug reactions. So often medicines are prescribed when probably a non-pharmaceutical approach would be better, and that's certainly where social prescribing can come in to prevent patients getting on medicines that are attempting to deal with social factors. So structured medication reviews are intended to reduce polypharmacy, adverse drug reactions, tackle overprescribing, and deal with and prevent dependence. There are some dashboards that PCNR's funded pharmacy teams can look at to see patients who are stepping up and into high dose opioids, and get to intervene at the what is considered the appropriate point, which is about 3 months, where if they're into high dose opiates and 3 months, it's going to be much harder to get patients off of those. And we all know the effects of that through the various opioid crisis information that we received. And also looking at things called FRIDS, which is falls risk inducing drugs, and there's a classification for those. Amber and red drugs are considerably higher risk for preventing falls and harms to patients. So I've highlighted some of the tools available that we fund. So there's regular training, Practice Plus, which used to be premium priced, £100 a year per person, but that's now funded through our license with Prescrip. There's regular networks that prescribers can use to talk to each other and mentor each other around structured medication reviews, because I mean, the elephant in the room is we're unsure of the quality. We can count structured medication reviews. There's a national dashboard, which isn't terribly user-friendly, as I allude to in there. So we are working with BI to turn it into something that we can monitor and look at the need for structured medication reviews based on number of unique medicines, which I've given some indication in there how PCNs perform. Any trends based on the number of structured medication reviews, and then doing a bit of audit work to look at the quality, because all we're measuring is that the read code has occurred, that a structured medication review has occurred. We don't necessarily know the quality or whether it's tackling appropriate or inappropriate polypharmacy, patients on too many medicines and some of which may be causing harms, etc. So it's we're getting towards measuring it and trying to influence the quality, and there's plenty of tools. I've alluded to the tools on Eclipse, which is called NHS Pathways, which can actually identify key priorities in terms of tackling key priority groups for structured medication reviews, and hopefully doing appropriate deprescribing and preventing of hospital admissions, etc. So these tools already exist. It's just pulling all the strands together, preventing people getting on medicines with social prescribing, reviewing medicines, monitoring medicines, doing structured medication review in targeted areas with get the best bangs for the buck, and getting people off of medicines which are likely to cause them harms, and just getting people to use those tools, measuring it, and working with the system to get the best outcomes. It's still in the PCN DES this year around structured medication reviews, and but we have an opportunity to attempt to influence the quality and the strategic areas to prevent medicines harms. So thoughts, comments welcomed.
Okay. Thanks, Michael. Welcome the sort of the, you know, this more strategic stuff. I think that's great. I think that's really helpful. While others are gathering their thoughts, I, you know, forgive my sort of layman's ignorance in this way, but I couldn't tell whether we should be happy or sad about the sort of the numbers that we're seeing for those structured medication reviews. So do we think we're doing the right number? Should we be doing more?
The simple answer is we don't know. I mean, the number is the number. It's literally counting a read code on a system, and it's really about the quality and reducing harms. So that's where we want to get to, doing a bit of audit work to look at trends and getting BI to be able to do a bit of smart monitoring of it, because it's not very easy to measure.
Okay. Do we have, before I bring Hein in, are there sort of benchmarking that we can do with other areas? Would they be capturing this?
That's what we'd like to do. We can't actually, using the national portal, we can't really benchmark one practice with all of the measures, because you have to go into either the practice or the PCN and drop down into each individual measure. You can't actually download the whole data set and do anything useful with it. It's I have fed that back nationally a few times. Nothing has changed yet. So as I say, I'm getting the BI team to do a bit of work on it for us, and hopefully they'll be able to do a data extract of some kind.
Okay, thank you. Hein.
Yeah, thanks, Michael. Like Debbie, I like the spotlight on some of these strategic themes, and I had a question about structured medication review, which maybe you still need to look into, because I remember many moons ago when these RS roles were created with clinical pharmacists, one of the key delivery items was doing these SMRs. So my question was going to be, does it meet expectation? But I guess that is still out in the open. It strikes me as a very relevant activity with also strong preventative potential linked to it. So interested to see more of that. But I like the report, and I had to look up the word polypharmacy, because I
thought I'd define it for you, because yes, because it's not it's not common parlance, and it just means lots of medicines. Yeah, true.
Yes. Good. Thanks.
Okay.
Andrew.
Yeah, Michael, I think I read somewhere in your paper about broad spectrum antibiotic prescribing being focused on, or the problem rather, being focused on a small number of particular practices. Do you have an idea what it is about those practices that causes the problem? And this, I mean, we've discussed this numerous times over the years. And why should it be still a problem? Because I'm sure none of those practices would, educationally, would be surprised.
Well, quite. We had an event this week, a regional event. Frankie Swords chaired it, and we had Naomi Fleming, the regional AMS antimicrobial stewardship lead, doing part of it for us on our local IPAC team. We do have one practice on our patch who is the national outlier on prescribing broad spectrum antibiotics. We've been working with them for quite some time, trying to change their behaviour. And it's a work in progress, is what I'll say. Clearly there are reasons why you would use broad spectrum antibiotics, but they are few and far between. At the moment, we're in the process of doing a bit of education to suggest that because of trimethoprim resistance, etc., you might use other drugs, and cefalexin may get sort of downgraded in terms of the broad spectrum antibiotics, but there's little justification for using the other two, Cipros and comoxiclavs in UTIs, etc. Without getting too much into the specifics, there is a little bit of misunderstanding and lack of following national formularies, which is a little bit disturbing and something we're trying to unpick. It's always going to be work in progress, and there's always going to be outliers, but it's not good that the national outlier is on our patch.
And is it the same national outlier? Would they be outliers for opiate prescribing and Z drugs and so on as well? Or?
They're not an outlier on opiate prescribing. You can go onto openprescribing.net and you'll be able to find them. It's in the data is in the public domain. But they were also at one stage the national outlier for hypnotics and Z drugs. Yes. Yeah. Yes. So it is a set of behaviours that need to be unpicked, and just a low threshold at which prescribing occurs, and prescribing should be, an appropriate threshold, and non-medical intervention should be considered first, or no intervention, delayed prescriptions, because patient in front of you may not need a prescription right now, but if the threshold is low, then that does affect the data, and I think that is the issue at this particular practice.
Okay. Thank you. Bill.
Yes, thank you. When we say practice, are we talking about one or two individuals?
It's a practice, and there are several GPs, etc., in the practice. Yeah.
But is it one or two individuals in that practice?
It seems to be the whole practice. Yeah.
Oh, okay. Right.
Yeah.
I'm just saying, because if we're getting no traction over a long period of time, and I know they're independent businesses and everything else, but if we're really talking about a relatively low number of people, then perhaps we ought to change the way that we intervene to make it much more about the person and their decisions rather than more generally. I mean, because what we obviously want as a result. Yeah. Do we have a sort of standard? I understand that it's difficult because they are a contractor and they're not directly employed, but I just wonder if we're talking about a number of individuals rather than a more broader issue.
Well, I mean, just coming back on that, there is a thing it used to be in the old GMS contract called Annex 8, which is around inappropriate or excessive prescribing. It's very difficult to enforce, but technically doing that is a breach of contract. We are in the new GMS contract, it's section 14.9, and we're just updating our old process so that there is a process in place should we wish to challenge it, and ultimately, that could be used, but we're looking at that and then perhaps publicising that to some practices who perhaps need to be aware that it is technically in their contract that they shouldn't be doing that sort of obvious high prescribing behaviour.
Laura.
Yeah, I know it's very early days, Michael, but I wondered if your team had discussed, in terms of antimicrobial stewardship, the Pharmacy First scheme, in that if a antimicrobial is given under a PGD, it has to be given in the correct circumstances. They can't obviously go off PGD. Therefore, that may be helpful, particularly when we're looking at things like UTIs. The practices where they're prescribing a lot for UTIs, have they considered referrals to pharmacy to free up some capacity themselves to look at the other issues? I know it's a very nuanced conversation, but where you're struggling to stop them from prescribing these broad spectrum antibiotics, actually, if they're sending more to the pharmacy and the pharmacy's having to follow the PGD for those particular items, that could be something to add to the mix.
Absolutely, we can pull off the data now. It's quite raw. It just gives us individual drugs by individual pharmacies. It doesn't tell us a great deal as yet. And alas, the surgeries we'd like to influence don't have a pharmacy nearby. So, but if they did, then clearly we'd be having that conversation, because on the whole, we believe that Pharmacy First will bring down prescribing of antimicrobials, because it's more strictly adherence to a protocol, rather than a low threshold at which they might be prescribed in some practices. Well, I think you're on mute, Debbie.
Sorry, it's because I've been coughing in the background. I put my thank you, Michael. There's a lot in this, isn't there? And there's so much always to unpack about the prescribing stuff. Maybe we're sort of out of time really today, but I think it's really just to re-emphasize. I think this is the right level that we should be looking at for us as a committee. So thank you for sort of responding to that. Perhaps we could put it up the agenda so that we're fresh and energized next time. I think that would be great. Just a sort of a passing comment from me, really. I think that as well as working with practices and people who do the prescribing, I think we should be empowering patients to ask questions about their medication more. Taking responsibility, understanding, thinking, wait a minute, I've now been prescribed this. Is this okay? Question mark. I think that might be another way to come at this, really. But we can pick that up at another time. Okay. So that takes us to any other business, and I can see that on there is a report about sort of access and recovery, access to primary care, that I think is there for us to note. Sadie, is that right? Circulated to us for that?
Yes, it's for information. It's the paper that went to the ICB board meeting last month, which all of the voting members would have seen by way of being on the board, but it's there for information for everyone else.
Okay, that's great. All right. Okay, well, thank you very much. So our next meeting is in September. Thank you everybody for the contributions. Some of the items have been far too interesting, haven't they? And we've got into them in a lot of detail, which is great. So thank you very much. For colleagues joining part 2, I suggest we convene at 3:45, and Sarah's asked me to remind people to log on to the new invite, not the original invite. Okay, I've done my bit. Okay, thank you very much, everybody. See you soon. Thank you.